All
You
right.
guys see any of that?
Yes.
Excellent. So I'll let you do your introduction and then we'll roll.
Yep. So it is my pleasure and honor to introduce to you Dr. Robert Keating, who is the chair of the Department of Neurosurgery at Children's National Medical Center, and he's faculty at George Washington University School of Medicine. Bob was my first junior resident in neurosurgery. The first month I ever spent, our chief resident was a guy named Tom Kay, and I blame the two of them for this lifelong torture of being a neurosurgeon, because it's thanks to them. They made me think it was going to be fun. Anyway, Bob is here to talk to us about Chiari's, and I will leave it to Bob.
Well, thanks, Ron. I could certainly spend the hour talking about Ron Alterman's stories, which might actually be more interesting than I talk on Chiari Malformations. But we'll save that for another day. And I will apologize in advance. I spent many hours trying to find pictures of Ron when he was younger. And I don't know if he's come into my house and stolen them. I could not find anything. So I do apologize for that. But I'm going to keep looking, Ron. And Chris, I'll let you know if I can find anything. Anyway, it's
my CIA connections.
Exactly. It's certainly a pleasure and an honor today to speak to you folks about Chiari Malformations. I'm going to tell you more than you ever wanted to know about Chiari Malformations, and actually it's backed up by data from our hospital, and I'll share that with you. It's going to be a lot of interesting stuff. I have no financial conflicts of interest. This is, believe it or not, I know there's not a lot of pediatric folks there, but this is pertinent to both the adult and the pediatric population. And I'll share some of our insight on our comparison of adults to kids and age and so forth. And a fair amount of research has been supported in the past by ASAP for what it's worth. So I have a number of objectives in this talk. First of all, I want to give you a broad overview where Chiari Malformation is today. We're going to define the condition. We'll talk about potential etiologies. And that'll be one of the key points of my talk today, is the value or the importance of the presumed etiology why you have hindbrain herniation. We'll talk about incidental Chiari's. We'll talk about the natural history. I'm going to talk a little bit about the comorbidity with the hypermobility syndromes, Ehlers-Danlos, and so forth. We'll talk about the significance of age, not only in the kids, but pediatric versus the adult cohorts. We'll share with you our 20+ year experience, closer to 25 now, here at Children's. Do you open or you don't open the dura? I will give you all the answers you ever needed to know. We'll talk about what to do with the tonsils, talk briefly about failures, long-term outcomes, but more importantly, my job is to keep you awake and bring some controversy to the talk. So I think the first question you have to ask is, what is a Chiari malformation? Is this a clinical condition? Is it a radiographic finding? Is it different for different ages? Does it change over time? Or at the end of the day, is it driven by the presumed etiology for the hindbrain herniation? There's a lot of questions that still remain. What is the significance of the X-ray? And we'll talk about the definition by Barkovich years ago. We're going to spend some time talking about the natural history and the incidental Chiari's that are very frequent nowadays. We'll talk about age, both in the kids and the significance of it, as well as the adults. We're going to talk about hypermobility syndrome and some of the comorbidities, how best to treat. Talk a little bit about the literature. We'll talk about the etiology and how it's important in defining how to treat the Chiari. And we'll talk about tonsil manipulation as well. And of course, outcomes and failures. Well, first of all, what is the definition of a Chiari malformation? I suspect everybody listening to this talk already knows this, but it's when the cerebellar tonsils are 5 or more millimeters below the foramen magnum. At the end of the day, it's a radiographic finding. And there's all types of variations on the theme on that. But Barkovich back in 1986 took 200 normal patients and 25 Chiari patients. And they found that if you went out to 2 standard deviations, it was 5 or more millimeters below the foramen magnum. And that's where that magic number 5 came from. And as we all know, it doesn't matter what the number is, it matters how tight it is. But something Barkovich said in his paper, and I'm sure you get the same thing we get from the radiologists, they quoted in the paper, it's probably better to err on the side of a false positive diagnosis. I would argue that's probably not true, and definitely not true in the setting of Chiari malformations, but nonetheless, that's where I think it started. There's a significant continuum. You've heard about Chiari zeros, you've heard about Chiari 1.5s. And of course, the question comes up, is this a reflection of a neuroanatomical continuum with respect to the different clinical presentations, or is it a different disease for different aged folks? At the end of the day, it's an X-ray finding. You can never forget this is a radiographic finding first and foremost. And as they teach you in medical school, treat the patient, not the X-ray. Again, I think most of you already know this. The presentation for Chiari's is very variable. It is age dependent. Little kids present differently than the older kids. We'll talk about that in a second. Headache, occipital headache, neck pain, Valsalva maneuvers exacerbating it. You name it, everybody has a different symptom, and that's why I put fill in the blank at the bottom. Presentation is also variable and is age dependent and can present with scoliosis, restricted neck motion, oculomotor paresis, increased tone. Again, a very, very variable picture in the setting of Chiari. So the real question always comes up, when are Chiari malformations on an X-ray clinically significant or relevant to what you're looking at when you see the patient? And again, this is not only true in kids, but very much true in the adult population. So let's talk a little bit about the increasing presentation of incidental Chiari malformations and a little bit about the natural history of this to know what's real and what isn't real. From a definition standpoint, the incidental Chiari malformations with the tonsils of 5 or more millimeters below the foramen magnum. If you really look at the patient and look for any subtle signs for Chiari and say to yourself, okay, this is pretty clean. They are truly asymptomatic. There's nothing even hiding behind anything. And at the end of the day, it has to be a surprise. It's unexpected. It's like, wow, I would never have expected this. This is completely out from the outside. So when you look at the MRI scans nowadays, they're increasing more than 10% a year in the United States. Not surprising, the United States uses more MRI scans than anybody else in the world, but it's not uncommon to have a lot of incidental things on the scans, incidental tumors, incidental Chiaris, you name it, it's out there. When you look at the natural history and how often this is found, there are many studies that look at this, that have looked at this in the past, and the incidence range is anywhere from 0.5 to 3.6. Bottom line is between 1 and 2%. So if you take 100 people, 1 or 2 of these people are going to have a Chiari and not know it. They did an autopsy study a number of years ago and it was 0.6, so it's definitely out there. Problem is we don't really know how these patients do long term. We don't have a lot of data on that. We have data from children that I'll present later on. There's no consensus on what to do with these patients, and it can be somewhat confusing. Cormac Maher up in Michigan looked at this a number of years ago. They had 148 patients found with incidental Chiaris. They tracked them for roughly 5 years. And at the end of the day, most of those patients did fine, but 10% went on to require surgery. So it's not a huge number, but it's a meaningful number, especially in a large cohort. John Jane Jr. at UVA looked at this more recently, again, tracked almost 100 patients for 10 years. And while most of them did fine, 7% went on to have clinical challenges, and a number of them ended up having surgery. So it's one of those situations where it's out there. Most people recommend being conservative, but there's not a lot of long-term studies. The studies have limited number of patients, so we really don't know the right answer. All the studies to date have been retrospective. We actually had a prospective study. I'll share those numbers with you in a second, been published. The management of the syrinxes, the management of it, who's an indication for surgery, what are the age issues and so forth are also all over the place. And there's often a mixed message. And well, most people would argue that you need to be conservative in this scenario, and I certainly support that. There is a legitimate number of these patients that do go on to get into trouble and eventually need surgery. So when we looked at this a number of years ago, this is old data, but it's still relevant. We started in 2006, 2007, seeing an upturn in the number of incidental Chiaris. I don't think it reflects that there was an epidemic going on. I think it was a better reflection of people recognizing this and reporting this, but we're getting about 50 a year, still are. And of course, then the question is, what do you do with these patients? And we wanted to look at this. And the question was, is this truly an incidental finding? Is this just an early manifestation of a disease that will become more common or more prevalent and visible when the patients are adults? What's the risk of needing an operation? What are the risk factors? Does it change over time? Are these kids any different than the kids that actually come to you symptomatic? And then in the end, how does age affect their presentation? And we looked at these patients, and anybody that had anything remotely close or could be construed as being Chiari related, these patients were excluded. We really wanted to have truly asymptomatic clinically normal, normal exams and so forth. Otherwise, they were kicked out. And these patients were getting scans for a variety of reasons. You can imagine in Children's Hospital, people getting scanned left and right, seizure workup, trauma workup, non-specific headaches, neurobehavioral ADHD. The endocrine clinic was working up kids that were small sized. We were a huge sickle cell clinic here. They all get scanned. So lots of studies out there being done. And not surprisingly, we're picking up these kids. So when we look back over a 20-year time frame here at Children's, we had almost 800 patients. We found that more than half of those patients were presented incidentally. And in that group, 12% of them had syringomyelia. In that entire group of patients, 13% of these incidental patients eventually went to the OR. What's interesting, I put this up there for the scientists that are watching this, and this is not a surprise. When we looked at just our retrospective data, 22% of these incidental patients went on to surgery. When I looked at the prospective data after 2008, it was below 10%. And so not a surprise. And again, the importance and the value of doing prospective studies rather than trying to find everything back in a retrospective fashion. It's interesting when we look at these patients, if the patients come in with an incidental Chiari and you do the rest of the workup, a significant percentage of them will have a syrinx, 11.6%. And generally, if it's a legitimate syrinx, it's a decent size, that's an indication for surgery from our end. I'll talk more about that in a little bit. So that was certainly promoting the numbers for surgery. If you take patients with no syrinx, no symptoms, and follow them over time, over average follow-up now is 6 years, and we have kids out 20 years, 4% went on to have surgery. So I think that's a more accurate or meaningful number from a natural history over almost a 20-year time frame. And at the end of the day, these kids, 80%, 78% do well, they're improved, meaning their symptoms get better or their syrinx gets better, and 5% go on to have repeat surgery. So the question comes up, can you predict who's going to have surgery, who's going to need surgery when you have a kid come in who's 8 years old and was in a go-kart accident, something like that? And when we looked at this, if the patients had a positive family history for Chiari, if they had a Chiari 1.5 where they have medullary kinking, or if they have tonsils more than 10 millimeters below the foramen magnum, they're at a much higher instance of having a symptomatic and surgical operation. So when we looked at all these factors, if you're younger than 5, tonsils more than 10 millimeters, Chiari 1.5, if there was evidence of maybe a little bit of early T2 changes in the cervical canal, suggestive of an early syrinx, or a family history, you had a much higher incidence, and we would follow these patients a little longer, a little bit closer. I put question mark tight craniocervical space. I got a lot of kids 15, 20 years out with horrible looking scans, 25 millimeters of tonsillar descent, no CSF space whatsoever, and they're fine. So I'm not quite certain, you would think the tighter they are, the more likely they have a problem, and that certainly works out a lot of times, but it isn't always 100%. This is an example. It's a 13-year-old boy in a go-kart accident. He has a concussion, he gets a CT, he has a Chiari malformation. And as you can see here, it looks relatively tight. Of course, they only do the top end of the head, so we don't know about a syrinx. He's asymptomatic, and lo and behold, he's got a legitimate syrinx in the upper thoracic canal. For us, that's an indication for surgery. We go ahead, we decompress the bone. We do intraoperative ultrasound to see if we're changing anything with the bone being decompressed and with the dural leaf being, outer dural leaf being removed, as they do in Japan. It didn't change much. We opened the dura. Tonsils are all gliotic, lots of scarring. We thought it was safer and better to put a stent in, especially in the setting of a syrinx, and obviously put a patch on. And here he is, 6 months, smaller to a year, and then by 3 years, pretty much gone. And obviously you can see the amount of space up here versus what we had here as well. So not an uncommon story. So let's shift gears a little bit and talk about Ehlers-Danlos or hypermobility. You would imagine correctly, we have a lot of kids with headaches, and they're dizzy, and they're tired, and they're not doing well, and they come in with like 33 complaints on the sheet of paper. And unfortunately, a lot of these kids have a Chiari when they do their workup as part of that. And not uncommonly, you're looking at these hypermobile kids with a modest Chiari. And the real question is, when are they connected? When are they significantly affecting each other? And the other question to keep in mind for this talk is idiopathic intracranial hypertension, or pseudotumor, the 800-pound gorilla in the room? So EDS is an umbrella term of connective tissue disorder. I generally just call it hypermobility. You can do blood tests, and often they're not necessarily helpful, but if patients are super mobile, or the skin's extensible, or they have dysautonomia, or they have aches and pains or POTS or irritable bowel, they fit that mode. And these kids come in frequently with scans. They've had headaches, and the scans show low tonsils. It's interesting, and you can see here, this is kind of characteristic. It's a Chiari. It's not the worst looking Chiari, and very often they have symptoms that are way out of proportion to what you're looking at on the X-ray, and that's the first clue. And these are some of the physical signs. I'm not going to go on a bite and scale. I don't want to kill all you guys at this early in the morning, but there's ways of measuring this and things you can do. And I always ask the patients, what can you do that no one else can do? And you'd be amazed at some of the things they come up with. It always makes for an interesting clinic. And this kid could completely turn his feet around and yet turn around and look at me from the front. So you get some pretty creative stuff. So we were curious, and since we have a fair amount of these kids, are they different than the kids that don't have the hypermobility? And we looked over a 16-year time frame and came up with 39 patients that had been very clearly defined as hypermobile kids, some with positive blood tests for EDS and so forth, and compared them to 248 surgical patients that had negative Beighton scores and so forth. And I'm sure there are lots of kids in that pile that were not being recognized. And this is a bigger issue for the adult setting because a lot of these patients are out there. And then the question is, do they have craniocervical instability? Is the angle of the clivus too much? Are they stretching their brainstem axons? And of course, they all have tethered cords and they need to have everything being done. I'm not convinced that any of this stuff is real. I certainly haven't seen any data that makes me feel comfortable in saying these patients need to be done. We're going to talk about more of that in a second. But when we looked at our hypermobile patients, 87% were female. And this is true in the adult data I'll show you in a second. But when we really look carefully at these kids and we compared the outcomes, if the patients had the right surgical indications, they were being operated for Chiari manifestations, not for the hypermobile headaches or aches and pains, the outcomes were the same. And the surgical approach is the same. 60% were open dural approaches with a durotomy and a dural patch, and 40% were bone only. And so the metrics are about the same. The surgical indications, okay, you guys can still hear me?
Yeah,
Yes.
All right, sorry, it looked like it faded on me here. So anyway, the surgical approaches, everything was the same. And we looked at the outcomes, except a little bit for the neurological presentation. Headaches were improved the same. The stringomyelia, the syrinxes got better the same. So if you're careful in picking your patient, at least the pediatric patients, they all did just as well as the other patients. Took them a little bit longer. So what about age, even amongst the different kids as well as adults? Is it a different etiology? Is it a continuation of the symptoms over time? Are the young kids different than the older kids? And are the adults just big kids in the long run? Again, there's been data on this. Rick Boop looked at this a long time ago and showed similar relationships between the two groups, the adults and the kids, but the kids did better. Again, not a huge surprise. Additional work coming out of Michigan, again, similar grouping and whatnot, the kids did better. And we decided to look at our kids a long time ago and broke it down to kids that were less than 10 versus older than 10. And not surprisingly, the older kids had a greater incidence of tonsillar herniation, more than 10 millimeters, more scoliosis, more often the syrinx, although it doesn't show it here. And the younger kids had more gait abnormalities. And in the end, the younger patients presented more often with brainstem findings, and these are 3, 4, or 5-year-old kids. And the older kids had more tonsillar herniation as well as whole cord syrinxes and scoliosis. And this would imply this maybe is a progressive process. When we look at this, don't even get crazy or try to figure out what's going on here. But you can see as the patients get older, and read that if it comes across, their symptoms are different. The symptoms are age related. And certainly as you get older, the likelihood of extremity symptoms, neck pain, scoli and syrinxes increases with age. So again, it raises the question, is this a continuum of a progression or is it a different disease? So we decided to look at adults versus kids. And we're very fortunate. We were able to get 5 adult centers over almost a 20-year time frame. We got 170 adults compared to 153 kids. And the average follow-up in the adults was about 1.5 years and a little over 2 years for the kids. And we were lucky to get the folks at Drexel, Georgetown, GW, the military hospital, NIH, to take the time and effort to put their patients to the same database that we had for the kids. And the interesting thing here is 86% of the adult patients were ladies versus 57.5% in the kids. The presentation for symptoms coming in, definitely more headaches in the adult population. Definitely more ocular symptoms in the adult population than the kids. This is actually wrong. It's supposed to be the other way around. There's more bulbar symptoms in the kids. And the outcome, again, not a huge surprise. 95% of the kids got better, whereas only 76% of the adults got better, and it was felt to be statistically significant. Syringomyelia, more common in the kids. Scoliosis, not a huge surprise with the syringomyelia, more common in the kids. And we would look at the degree of basal invagination, slightly more common in the kids. And if you look at some of the other things, scoliosis and syringomyelia, as I already told you, more common. Outcomes, the kids did better, statistically significant. And so at the end of the day, and this has actually been submitted, so hopefully it'll be in press in the next few months, the differences were the adults predominantly were female, more bulbar and apnea and the symptoms of apnea in the kids, syringomyelia and scoliosis more in the kids, headache more common in the adults. And in the long run, the symptom resolution was better in kids. And this is in the setting of similar surgery, similar indications of surgery, similar complication rates, and similar redo rates. And I would argue this would point out that the adult patients with Chiari malformation are different. More often they're complex Chiari, more often they have, the hypermobility conundrum and so forth. And it's a different group of patients, a different disease. So let's talk about etiology. And this is really, I want to put the emphasis of my talk today. You've got to look at the etiology or presumed etiology for hindbrain herniation to try to figure out what to do. And the different symptoms present probably for different reasons. And certainly syringomyelia is going to be different than a neurological finding and so forth. And if you don't know what the likely etiology of your x-ray finding is, you're going to have a rough time treating it. And I'm a keep it simple kind of guy, KISS philosophy. I'm going to give you 4 reasons to have hindbrain herniation. 1, posterior fossa is too small. And not surprisingly, if the posterior fossa is too small, the toothpaste gets squeezed out of the tube. I'll share with you some data on that. 2, you can't get the spinal fluid out, the foramen magendae or Luschka, it's blocked. It takes the path of least resistance. It goes down the central canal and gives you a syrinx. 3, you've got pressure from up above, and the pressure from above could be pseudotumor. It could be unrecognized hydrocephalus. It could be pansynostosis. Again, something you don't deal with in the adult world, but we have lots of kids that have multiple sutures and they end up with a Chiari malformation. And then fortunately, the rare but real craniocervical instability, the hypomobile kids, the true EDS patients, they represent only 2% of our patients. I mean, tremendous challenges with this, but they do exist and so forth. So we published this a number of years ago, and again, it's not a huge surprise. You have a small posterior fossa, often seen in the little kids. The bigger you make it, the better they do. I know Ron's going to say, well, wow, that's earth-shattering, but at least we're able to show it objectively. Mark Quigley's been working with us. Is CSF flow the holy grail? And I think there are a lot of folks, certainly John Heiss and the guys at NIH, as well as other places would argue CSF flow is key. And remember, you're looking at a sagittal flow study. It's one plane, it's one view. It tells you nothing about the 360 degrees around the brainstem. It tells you nothing about diastole and systole and all the other things. And so there's a lot to be said in trying to figure out when is flow normal, when is it abnormal, and when is it predisposed the patient to having a problem. And this is an example of a young man. We have a lot of kids like this now with pseudotumor. He's 22 months. He's having headaches. He can't see. He's got significant papilledema. Here's a scan. Doesn't have hydro. He does have a small Chiari and he has a syrinx. And lo and behold, his pressure's in the 30s. When they tap him, his CSF is clean, and he's diagnosed with pseudotumor idiopathic intracranial hypertension. He's treated with Diamox, serial taps, headache gets better, papilledema gets better, his pressures come down into the 20s. And you'll see as time goes on, the syrinx gets smaller, his tonsillar herniation gets better. And so you always have to wonder, is something happening upstairs? Do they have pansynostosis? And it doesn't always come across. It can be occult. But the reality is the problem isn't at the cranioscervical junction. The problem's up above, and you need to fix the problem first. So with treatment, just a brief overview of what we've done for 20 years. We're now well into 1,000 patients. About half of them are incidental, a little more than half. 26% go on to getting surgery, and I'll tell you the reasons for that in a second. And about 22% have syringomyelia, which is an indication of surgery in our set. So our indications here, and this has been steady in the 25 years I've been here, intractable. You can't live your life the way you want to. You can't go to school. You can't play sports. You can't go to work. Truly intractable occipital Chiari-like neck pain. Frontal headaches, aches throughout is not the issue. It needs to be a Chiari-related or likely Chiari-related headache. That's an indication of surgery because the outcomes generally support the risks. Anybody with a neurological issue, increasing spasticity, sixth nerve palsy, apnea, sleep apnea, obviously for reasons everybody understands is a reason to decompress the posterior fossa. And syringomyelia, and not just a prominent central canal, but legitimate syringomyelia where you can have long-standing. I have a bunch of kids now. They presented with scoli. They had a large syrinx. They had a Chiari. We fixed the Chiari. Syrinx got smaller. Scoliosis got better. And they still have intrinsic wasting as they're going into their 20s now. It just never got better. So you can get permanent, irreversible changes in the setting of a long-standing large syrinx. So when we look at this, more than half of our patients had progressive symptomatology leading to surgery. It's interesting that 47% of the patients came in with syrinxes, buying them an operation, at least a recommendation operation. What's fascinating to me is that almost 6%, a little more than 6%, didn't have a syrinx, developed a syrinx, and then end up buying an operation as well. And nowadays, and this hasn't really changed much in the last 10 or 15 years, 60% of the patients get the blue plate special. You open the bone decompression, you open the dura, they get a graft. 16% end up getting a fourth ventricular stent, and then about 40% get the bone only. 77% of our patients, actually a little bit higher now, closer to 80-some%, are better, meaning the symptoms are better, the syrinx is better. Used to be 9%, end up getting a second operation. We're now down to closer to 5%. And our complication rate for bone only is 0.4% or 0.5%. It's a bigger issue when you have an open dura, you've got CSF there, and the majority, and I consider a pseudomeningeal a complication because if the patient's back in the hospital and the parents are unhappy, trust me, it's a complication. Not everybody feels that way. We've not had any significant neurological complications, but we've had a lot of plumbing issues, and I think that's one of the downsides of opening the dura. Again, the goals to fixing this is to restore normal CSF flow dynamics, and at the same time, to minimize formation of scarring or arachnoid adhesions. And so from a definitive treatment standpoint, you've got bone only, including an outer leaf turectomy. You've got opening of the dura as well, with or without a fourth ventricular stent. And then we'll talk about tonsil shrinkage. Considerations at the time of surgery, open versus closed, and we'll talk about that in a second. We do use intraoperative ultrasound to gauge whether the tonsils are doing better as we're going through the process. And of course, what about duroplasty and God forbid if you have to fuse them or not. It's a bit different in kids than it is in adults. I'm not going to go crazy with all this to open and not open. There's data on both sides. I think it's becoming clearer over time who's a candidate for bone only. And it's becoming clearer who needs to have more than that, really does need to have exploration of the CSF spaces and so forth. We do use the ultrasound at the time of surgery for most of these kids. It tells us a lot. If we've done the bone decompression, we've done the outer leaf turectomy, how do the tonsils look? Are they less pulsatile? Is there more space between the tonsils and the brainstem? Are the tonsils higher? Have they come up? You can actually learn a lot. And if you've seen an improvement in your tonsils, you're probably done. And that's usually what we try to sell to the patients and the families. We'll see how things look. The odds are in our favor. We probably don't have to open the dura. The ultrasound will help us with that. And you can see here, the tonsils are low. And here, this is just doing the bone and the outer leaf of the dura, and the tonsils have already come up. They're a little bit more rounded. We're done. We don't need to open the dura. We don't need to go after any more morbidity. Patients home in a day, and 80-some+% of the time are they doing better. And then, of course, when you do the bone decompression, what about the dural splitting? I like to do that. It takes longer to split the dura than it would be to open the dura and put a patch in. But the real trick is who's a candidate for bone only and who needs to have the bigger operation. And that's an important thing to try to figure out. When you're doing the dural decompressions, do you leave the arachnoid intact? What kind of duroplasty material do you use? How big a graft? And then obviously, you have to deal with the potential complications with any leaks, any adhesions, infections, and so forth. I'm an organic neurosurgeon, so I generally like to use the pericranium, but there's certainly nothing wrong with using other materials. And then what do you do with the tonsils? You leave them intact. I'm going to give you an argument why you try to leave them intact. You shrink them. I've had neurosurgeons cut the tonsils out. I've had neurosurgeons, I've seen Obex plugging. What do you do for CSF flow? And at the end of the day, like everything else that we do, what's the benefit? What's the risk? And God forbid you've got the kids that are unstable and they have the brain, they have the head sinking on their spine. You've got to jack them up. You've got to fuse them, decompress them before you do all that. We really have to be very careful on the pediatric spine, the kids that are growing. And it's interesting, we probably have to do this once every 3 or 4 years. It's not that common. And we're extremely conservative before we decide to fuse them as well as decompress them. I've had a lot of kids with pseudobasal invagination. It's not terrible, but it's concerning. And 10 years later, it looks exactly the same. And you've decompressed the Chiari and they're doing fine. So when we look at this, as I said, most of the time we do the duroplasty and the patch, roughly 60% of the time. I put a stent in 16% of the time, and then 40% of the time we just do the bone only. And with the ultrasound, it's adequate, and we feel good about that, and it works. And just through the process, we take C1 off. We do an ultrasound first. We take C1 off. Does it look any different? Generally not. We take the posterior fossa of the rim, and you don't need to go that high. You don't need to get any cerebellatosis or brain sag, but you do need to go lateral as much as you can because, again, removing just the middle 30 degrees of that 360-degree curve, not going to do much. You want to get out more towards the condyles. I'm not saying take the condyles, but get out there so you can decompress a larger part of that arc. And we do the ultrasound. If the ultrasound looks like we're making good progress and we're happy with the tonsils, we'll call it a day. If we're not, then we'll go ahead and go in and open up the dura. And then it's just a question of looking at the adhesions. If it's really stuck down, if Pike is in the middle of some adhesion, or you're concerned that no matter what you do, they're going to scar down again, we'll throw in a fourth ventricular stent. And I generally, going back to this, I prefer, and I'll show you why in a few minutes, we generally try not to obliterate or coagulate the tonsils. Here's an example of a 12-year-old boy with scoli, otherwise healthy kid, 26-degree curve, and lo and behold, his ultrasound shows a large syrinx, and lo and behold, he's got a significant Chiari. This is 2010. I wouldn't do this today. This is what I've learned, and maybe it's a take-home point for the talk. We said, look, you're not having any symptoms. You got a little bit of a curve. We'll do the bone only. We'll do the ultrasound. We'll see how things look, but we're hoping that'll be fine. The ultrasound looked a little better. How much is a little hard to say. Tonsil looked a little rounder. He said, all right, we're done. We've cured this kid. He sent him home the next day. There were obviously no complications. And here he is, 11 months. I wouldn't say we've done much for him. You can argue there's a little more room up here, but not very good. And here he is, 20 months, and here is 26 months. And still asymptomatic, but his curve is increasing, as you would imagine. So we brought him back. Family's not wild about a big operation, but we pushed it and brought him back, and he had lots of adhesions. We did the duroplasty. We put a fourth ventricular stent in, and here he is here. We opened things up. Lots of scarring. Obviously, that wasn't going to get fixed with the bone only. You can see he's all socked in there. We decided, because of the amount of adhesions near pica, is safer and easier to put in the fourth ventricular stent, especially in the setting of an increasing curve and a pretty impressive whole cord syrinx and a graft and so forth. And here he is. Beforehand, big syrinx, 6 months post-op, it's getting smaller. And here he is, 18 months. It's a lot smaller, and his curve is down to 16 degrees, and he never needed to be fused. So what about the outcomes? How do these patients do? And again, there's a lot of literature. I'll just share with you a couple of publications. Jerry Oakes and his 500 cases of kids, 85% better, only 2% complication rate. Jerry does not consider a pseudomeningocele complication rate, but nothing serious, and 3% went on to have a reoperation. All good numbers. His clay clamp study as well, lots of patients, 371 patients, 82% were better at 3 months. Morbidity was low at 2%, did have mortality, and his recurrence rate was 7% at 5 years and a little bit less than 9% at 10 years. When we looked at our stuff, 77% of our patients were better, 9% had another operation, and as I said, our complication rate was 15%, but this is predominantly CSF issue. We didn't have any neurological complications, fortunately, or anything to write home about. It was predominantly pseudomeningoceles, and some of these kids went on to get a shunt. 5% of these patients ended up with a shunt to deal with that. So how do these patients do, open versus closed? Neil Feldstein and Rich Anderson up at Columbia, huge advocates of just bone only. As Neil would say and has told me, Bob, give them enough time, they all get better. 91% of the patients at resolution of the symptoms and or syrinx, well, 70% improve with the syrinx. But even then, 9% of those patients still had reoperations later on, although their complication, the morbidity rate was low. This is Dave Daniels out of Mayo, did a meta-analysis. Patients that had the bigger operation, the duroplasty and so forth, had better overall clinical improvement, statistically significant, a longer length of stay, and obviously more complications. And as far as revision surgery, blood loss, or improvement in the syrinx to scoliosis, they didn't see any difference between bone only and opening the dura. And this is a study out of Italy, same concept. The bone only patients did well. You can find plenty of articles in both regards. We looked at this a long time ago and found out that when we looked at bone only versus opening the dura and putting in a stent, our improvement rate in either the syrinx and or the symptoms was the same in about 63%. Reoperation rate was less for opening the dura, although statistically not felt to be significant. Not surprising, the complication rate was much higher for opening the dura. Here's a take-home point, and this is what I've learned in 25 years here. When we looked at bone only and looked at the degree of the syrinx, the size of the syrinx, grade 1, less than 25% of the diameter, grade 4, more than 75%, the whole accord syrinxes, 30% got better, but a lot of kids didn't change at all. And frankly, if you're operating on a syrinx, you're worried about scoliosis or something else. If they're not getting better, that's a failure. If we looked at the open and the duroplasty and sometimes a stent, a significantly greater number of those patients got better. So when we see kids now that have a large whole accord syrinx and not the world's most impressive Chiari, we know they have a CSF outflow obstruction. We're going to open the dura 95+% of the time. What about failures? What do you do with failures? So there's not a lot out there in failures. People don't like to write about failures. How do you define it? What are your objective measurements? And then how long a follow-up? Are you talking about a failure at 6 months, 5 years? And then what do you do with that? And the reoperation rate's anywhere from 8 to 30% in the literature, and people use a ballpark number of 10%. This is the stuff out of NIH, and they looked at their failures. John Heiss wrote this with Ed Oldfield a long time ago, but in their setting, 10 of their 16 failures were adhesions that had not been adequately addressed or perhaps grew back. And then there were a number of patients that didn't have enough bone removed and so forth. Mike Scott looked at failures. They had 9% failure rate at Boston Children's. And again, when they looked at this, a lot of times there were adhesions. And you need to follow these patients over a longer period. 1 year is not long enough. And at the end of the day, almost half, 44% of Mike's patients required a fourth ventricular stent. When you decide to put a fourth ventricular stent in, if the adhesions are impressive and you're worried about causing damage to surrounding structures like pica, if you sit there and say, wow, I'm gonna have a hard time getting in here, I know it's gonna scar down in the next 6 months to a year. I've yet to have a fourth ventricular stent fail, and we put a little stitch in so they don't migrate, but I don't do it unless it's really necessary. But in the long term, they work out very well. And this is something I think important to point out too. Rich Anderson wrote this paper a few years back, pointed out that in their experience, since they don't open the dura, it could take up to 2 years to see resolution of the syrinx. So you don't have to necessarily give up and go back to the OR if a year out the syrinx hasn't changed much. You really need to let them go out a number of years before you can call it a failure. When we looked at our failures, when we looked at bone only, it was 14%. When we looked at opening the dura, it was 7%, although statistically, it was hard to say that was significant. But we went back and looked at these patients, both bone only and opening the dura. 17 of the 19 patients had scarring of the fourth ventricle outflow. Now, that's understandable for the bone only. We never even looked. But for the other patients that actually had the open dura and looking, either the scarring, the adhesions were inadequately addressed, or they grew back. And then again, about half of our patients required a fourth ventricular stent. So is tonsil manipulation evil? And I was going to try to get a picture of Putin, but didn't have the time. But you can pick your evil candidates or not evil for those of you that are fans of Putin or Trump or anybody else. It always seemed strange to me, and it didn't really make much sense to create more scarring and adhesions at the craniocervical junction when this is a choke point for CSF flow from the head into the spinal canal. And so we actually in 2008 kind of took a different philosophical approach. Before 2008, everybody got the tonsils cauterized. It was fun. They disappeared. The post-op scans looked great. And this was a universal process. After this, you started saying, do we really want to do this? Because I can guarantee you, and any of you that do Chiari surgery, you cauterize the tonsils, you manipulate the tonsils, the patients are not happy. They're throwing up, they look miserable for a day or two. They get over it, but they're not happy. And so when we looked at this, we looked at the two cohorts. They're very similar in indications for surgery, the demographics, the age. We did have more syrinxes as an indication in the later group. I think we became a little more, you need to prove to us you need to have this, but everything else was the same. And we looked at the repeat surgery beforehand, we were roughly 13.5%. When we looked at the repeat surgery in the later cohort, we're down to 5%. And complication rate was the same, the improvement was the same, but there was definitely a difference in the repeat surgery. And so here's repeat surgery in the first time frame, 13.3 versus 5%. Here's the number of patients that had tonsil ablation in the first time frame was 74% versus 42. We still do it, but a lot less. And then when you look at this, here's bone only repeat, 9%. The bone is open, the dura is open, and we are not manipulating the tonsils, the same or close to the same for the repeat. And when we did ablate the tonsils and manipulate them, we have almost 24% repeat surgery in that particular group. So I'm going to wrap up now and try to give you the key points. I'm sure we're running out of time. From the pathogenesis, people still debate, what is a Chiari malformation? Is it the right name? What's causing it? And remember, this is a clinical picture, a radiographic picture, not necessarily a clinical picture. I think the pathogenesis still remains a little bit unclear. As a keep it simple kind of guy, I break it down really into 4 areas. The posterior fossa is too small, you make it bigger. The CSF outflow is restricted. You get rid of that choke point. You allow that CSF to flow around the brainstem rather than down the central canal. You've got a problem up above. The head's not growing. You've got pansynostosis. You got pseudotumor. You fix it, or you got unrecognized hydrocephalus. Remember something. If you've got hydrocephalus and you got a large syrinx, your syrinx is your 5th ventricle. So you can't necessarily say that the ventricles are small or isn't hydrocephalus. But that's where the problem is. Fixing the Chiari is not going to solve that problem. You're going to end up with a CSF leak and God knows what else. And then certainly if someone's unstable, you need to fix that. And I put question mark around tethering. I remember Arnold Menezes talking about this as well. I've operated on close to 1,000 tethered cords in my career. I've certainly operated on hundreds of Chiaris. I've only seen 2 times in that, and we always check the whole cord, where there was legitimate radiographic evidence of a tethered cord and a Chiari. So I'm not saying it doesn't exist, but I would argue that you have to prove that. The natural history, we're seeing more and more of it. It's out there. It's at least 2% of our patients. We don't have a lot of studies. I think ours was the first and the largest prospective study showing that roughly 4% of these patients start off with nothing and go on to get into trouble. It is interesting, I didn't comment on this, but if you don't have a problem, usually by 3 years, you're not going to have a problem. Though we've had a couple of kids out later, but it's a handful of patients. And if you have family history, you're younger than 5, you've got a 1.5, your tonsils are lower than 10, you are definitely at a higher risk for having a surgical indicated Chiari. As I said before, we're not saying that everybody should have an operation, but roughly 4% of these patients that had no syrinx, no issues, no problems, go on to get in trouble. And then we do find a fair number of these patients that found incidentally. You do need to look at the whole spinal canal. You can't just take that, the head MRI that goes down to C3, C4 and say that's okay. You'd be surprised. Very often it's hidden. As far as age, the younger patients are definitely different from the older patients. Don't know if it's an issue of time or different etiology. Younger patients have more brainstem symptoms. The 3 and 4-year-olds come in with apnea, eye findings, and so forth. As you get older, not surprisingly, the degree of tonsillar herniation increases. It's progressive. As you get older, not surprisingly, you have more holocord syrinxes and scoliosis. When we look at the adult versus the pediatric population, papers in PrEP, 86% of the adults are female versus 56% of the kids. This is a different condition. This is a different disease. More bulbar symptoms, apnea in the kids, more syringomyelia scoliosis, more headaches in the adults. And in the end, the kids do somewhat better from a improvement standpoint. And I would argue the adult that we see, especially since most of these ladies, probably reflects a complex Chiari, the hypermobile patients, and that's a whole different ballgame. Open versus closed, no question there's patients that do very well with the closed bone-only operation. You don't have to do a duroplasty. The trick is figuring out which kids those are and keeping it simple. Your morbidity is a lot less for bone-only than it is for opening the dura. And I think in the end, it's most likely dependent upon the etiology. If you've got a holocord syrinx, you're going to have to open the dura. As far as outcomes, generally people give 80 to 90% success in reducing the syrinx as well as symptoms. The morbidity runs anywhere from 3 to 15%, probably reflective of an open dural repair versus a bone only. And reoperation rates generally run around 10%, although we've been able to reduce that to 5%. I think more because we picked the patients that need an open versus needed a duroplasty versus bone only. And our complication rate, not surprising, has come down because we've been able to do more bone only than opening the dura. Not a lot of literature about failure. You do need to follow these patients over time. Reoperation rate is at 10%. And our reoperation rate has dropped, I think, because, again, better recognition of who needs bone only versus opening the dura. And we will put in the stent if we're reoperating at least half the time, and this seems to solve the problem. As far as the tonsils, still controversial, but I would argue it doesn't make a lot of sense to go in there and be coagulating and frying the tonsils where you have the CSF trying to flow out of there. Our reoperation rate has dropped because of that. We're down to 4.9%. And in the future, as we have a better understanding of the physiological, the hydrodynamic factors, it'll get easier to figure out what type of operation is necessary. Back to the etiology, look at the presumed reason why those tonsils are low. If you can figure that out, or at least think you figure that out, you have a better shot at fixing that. Genetic parameters are key. Why do all these EDS or these hypermobile patients have Chiari's? It's got to be some genetic connection there as well. And I think, again, stratifying the diagnosis to the treatment will give you more success and less morbidity. So in the end, do the right operation for the right reason. If I can leave anything as a message, look at the presumed etiology where those tonsils are low. It's an X-ray finding. You've got to figure out that first. And in the end of the day, less is more. So I'll stop there, and there may be a couple of minutes for question. Thanks. Everybody still awake? Is Ron still awake? It's tough.
Yeah, I'm here. I'm in my car though now. So fantastic talk as expected. Really appreciate the perspective. Incredible numbers. I don't have any pertinent, insightful questions, but I'll throw it open to the rest of the audience.
Hey, Bob, that was it's just great to hear a talk so weighted with the experience you have. It's phenomenal. But it sounds like ultrasound really changed your algorithm of how you manage these mostly kids intra-op. And the question is that true? And it looked great that you use it. Because as you remember, when a lot of us were trained, it was only open, closed hadn't even been considered yet. And the question is the percentage of patients where you do open because of ultrasound guidance, the same in kids and adults? I might have missed it. You might have said that.
Yeah, no, I mean, unfortunately, it's a great question, Chris. We've not asked the adult centers if they were using ultrasound. My impression is the adult centers more often not do the open, the duroplasty and whatnot. And so the ultrasound is probably just a meaningless adjunct. It doesn't add a lot of extra time. We do have to look at that and come up with when did the ultrasound persuade us. I think now I go more on, I know what the presumed etiology is. I know I'm going to have to open the dura. We'll do the ultrasound, but it rarely dissuades us from that. But I know there were a few guys, particularly down in Texas, doing intraoperative MRI to see if things had got better as well. I think if you know why those tonsils are low, if you think you know why those tonsils are low, then you can tailor the operation. If it's a CSF outflow thing, you need to get in there and reevaluate the outflow, the junction, the OBEX and all that sort of thing. If it's too small a space or upstairs, it's tight for whatever reason, that's where you need to focus your attention.
Meaning a shunt? I mean, if they have hydro and a syrinx, do you just shunt them?
Yeah, that's a board question. Where do you start? And obviously, if somebody has hydro or you're suspicious they have hydro, and it's hard, because if you've got a gigantic syrinx, that's your fifth ventricle. But if you're suspicious of that, you're probably better off starting over the shunt or potentially even an ETV. You can make an argument for that to try to avoid silicone toxicity, so to speak. But yeah, I would start there first and tell the parents. I can't tell you, Chris, how many times I've said, I don't know, the ventricles look okay. Let's start off with the operation. And there you are 3 months later putting in a shunt. I'm getting tired of doing that. And the parents look at you like you don't know what you're talking about. More data is what we need.
Dr. Keating, this is Dr. Tripler. I really enjoyed your talk. I didn't think I would be so rapt for a Chiari talk, but you made it very clinically relevant. So, and we always struggle to operate on the right patient because we all know, especially in the adult population, operating on the wrong one is very painful. And you showed that, right? That they don't get better as much as children. And I think that's just the co-founders and that's not being able to just select the correct patients. I have so many questions. So I stand. So talk to me again. Like, you don't burn the tonsils. When do you put a stent in? I have to say I burn the tonsils if I think they are tight and I think there's no CSF and I want to open it up, but I've never placed a stent. Can you talk me through this a little?
Yeah, that's a great question. And Dr. Stibler, if you notice, I was going too fast probably, but we still will. And again, there's 5 guys here, and then they all do their own thing. Although I think we're kind of on the same page. We still manipulate or address the tonsils about 40% of the time. It's less than half. And there are times that the tonsils are just jumping out, falling out. It's just crowded in there. You can't see anything. A little judicious, careful medial and inferior tonsil coagulation's probably in the best interest of the patient. I stopped addressing the tonsils or manipulating the tonsils. I'm just tired of having the kids thrown up for 2 days and the parents being upset and whatnot. I still at times are stuck. You'll see the tonsils, you can't get anything done. And so I will do something. I think with a decent patch, you can give yourself a lot more room. Even if the tonsils are relatively full, that will generally do the right thing. As far as the stents, I'm proud to say in that huge series of patients, we've never had a post-foster infarct. We've never had anything considerably challenging from a neurological perspective. So, that means we haven't done enough, I guess. But we've been fortunate in that respect. If I've got somebody who's got super glue in there, and I've seen redos, this is classic, and one of our papers shows that this great case where they went in, they just annihilated the tonsils. I think they brought in fire, and the tonsils were all scarred in there. And it was like someone poured super glue in there. It was a nightmare. And this person, not surprisingly, had done better, and the syrinx came back and they were miserable. They actually had tethering of the brainstem and were having all kinds of issues. So if I'm in a situation where it's really socked in there and there's pica and it's all caught in there, and I'm worried about not only exposing and getting enough room and having the Obex freed up so we can get CSF to pour out, the better question is what's going to happen 6 months from now? Am I going to be back doing this again? I'll throw in just the top of a T-piece from a lumbar drain, and I will put in a 5-O-Proline to one of the holes, and I will snake it in. If you don't want to jam it in, I know some people use a shunt tube, just let it float in there, and then I will bring that out and put it along the superficial part, just underneath the arachnoid, or underneath, I should say, the dura down to C2 on the side, and put that 5-O-Proline into the dura so that it stays there. I've also seen patients come in from elsewhere, the stents move. It's hard to see. Sometimes a T2 MRI will show it, or a CT scan, but I've yet to have any of them fall out. The question comes up when I've had 1 or 2 patients show up 6, 7, 8 years later with a redevelopment of a previous syrinx that went away, and now it's back, but the stent's been in there. They've just scarred in around it, but they've done okay. So if you're really stuck and doesn't look good and you really don't want to deal with a pica infarct, or you're worried about long-term issues, I think the cost of putting in a stent, a judicious stent, not something up the aqueduct, is well worth it.
Thank you. I have one more question, and that, so when I see, I only see adult patients, and everybody has a Google search before they show up. As you said, this patient have multiple symptoms. You can contribute every symptom to your Chiari. This patient have a long journey, and finally, hooray, there is a radiographic abnormality where they put all their hope on to fix all their problems. Yeah. So I have you, of course, if there's no syrinx, I think a syrinx makes the decision process a little bit easier, at least in my world. But if there's no syrinx, if you don't have the typical Chiari headaches, I kind of use the Cine MRI, the flow study, as of, there is normal flow. I know you have all the symptoms. So kind of a way out if I'm not convinced that the symptoms correlate. But you don't think we should rely too much on the Cine MRI?
No, I think I applaud you for being conservative and careful. I've seen too many kids come in, they walk in, and they say, oh, I had a fusion. I said, oh, I can see. And it isn't so much that they've been through the mill and they didn't get better. It's the psychological impact that after all of this, they are no better. So back to your, yes, I think CSF flow studies we do on all our patients, we're trying to quantitate them, put them in objective data. It's hard to do that, but there's no question. Someone comes in with 9,000 symptoms. The tonsils don't look that bad to you, and their Beighton score is 9, and you're like, okay, I know where this is going. And you got a nice CSF cine flow, ma'am, probably ma'am, this looks great. I don't think this is related. You can find somebody else to detether your cord or fuse your neck. There's plenty of those people out there. It's just not worth the RVUs to do that. So I applaud you for looking at that. And I think that is a valuable way of using a study that's more subjective today, hopefully objective in the future, to try to find. Also, let's say you got a miserable cine, kid looks tight, you open them up, they're looking better, they feel better, the syrinx gets better, whatever that may be. And then 4 years later, they're starting to have symptoms again. And you go back and the cine went from bad to good, back to bad again. It also helps you there too. So I think you're doing the right thing with that.
Okay, thank you so much. I really enjoyed your talk. Very applicable. Thank you.
Great, thanks.
Over the years, we've seen patients with pseudo-ulnar lesions without syrinx. Have you got any thoughts on the etiology of that?
I missed the first part of that. I'm sorry. You said you see what without?
Pseudo-ulnar, wasting of small muscles of the hands.
Sure.
How come?
Yeah, it's a great question. I certainly would work them up from a neuromuscular standpoint. I would do the EMG and the nerve conduction tests. I can't say I've seen, well, I shouldn't say that. I have seen significant Chiaris with wasting, but usually they've been in the setting of a syrinx. And I've had some of those kids, we've made them better from respect to their syrinx and their scoliosis, but they still have wasting in the hands later on. So I think in the adult population, that's probably a bigger concern from a neuromuscular standpoint. I can't say that I've seen a lot of Chiaris just with that and nothing else. But if they had a lot of neck pain, I've seen ADHD kids with it, and Asperger kids get a little bit better when they've had other symptoms. So I don't think we know all the answers, and I'm not saying it's wrong to do that, but I like to have something else to hang my hat on to say, well, they had a lot of occipital pain, they had some weakness in the intrinsics, but I would be more worried about some of the neuromuscular stuff that might go along with that.
Well, Bob, I think our time is short, but I want to thank you again and Ron for having you. It's been great to get to know you a little better, but also great to hear this talk. And there might be some follow-up you may hear from some of us.
Yeah, I'm happy to answer any questions. It's just R. Keating at Children's National. So let me know, or feel free to torture Ron or Chris for that matter. But anything I can do to help, happy to discuss. And we do see some older patients. So if you just want to, hey, what do you think of this? Run it by me. Ron, quick question for you before you hit somebody and you're driving. We've started doing HIFU for central tremor. Are you guys using HIFU yet?
Little can of worms there, Bob.
Read my papers.
All right. I'm not saying for Parkinson's, for essential tremor.
No, we're not doing it for essential tremor.
Yeah, we had a board member's husband the other day. It was impressive. We were using it for tumors as well. And we're thinking about some of these disaster dystonic kids. But, you know, guy comes in like this and he goes out an hour later. It was very impressive.
Wait. So we're going back to Cooper. You're going to burn more holes in the brains of kids with dystonia.
Well, he was a sailor. What do you want?
Very disappointing. Very disappointing.
All right, we'll have this discussion another time.
Absolutely.
Great.
Absolutely.
All right, gentlemen and ladies, it's been a pleasure.
Over some Turley.
Sounds good. Got plenty of it.
Thanks, Bob.
All right, folks. Appreciate it. Thank you.
Take care.